to S53. We're going to do a quick walkthrough because our ledge council has to get out of here. But we can't move on to the rest of our testimony until this happens.
Great. Good morning again, Jen Tarvey from the Office of Legislative Counsel. I think you can see the bill. This is S53, an act relating to certification of community-based perinatal doulas and Medicaid coverage for doula services. For those of you who were here last year or who were not, this came out of work that was done in this committee and others. In the last biennium, there had been interest in Medicaid in creating Medicaid coverage for the services provided by doulas, which you'll learn more about in a moment if you're not familiar. And the Department of Vermont Health Access wanted to have, to be sure that there was certain criteria that were met for providers in order for them to reimburse for the doula services, and there was no kind of regulation for doulas. So the Office of Professional Regulation was tasked with doing a sunrise review of doulas. They came back with a recommendation for voluntary certification for community-based perinatal doulas, which is what you see in here. So this creates a new chapter in Title 26, Chapter 84 on community-based perinatal doulas. It starts up with definitions and sort of feed each other, but by the end you should have a pretty clear sense. So it starts with definitions. Certified community-based perinatal doula is a community-based perinatal doula who holds a certificate issued pursuant to this chapter. A community-based doula is an individual who provides doula services to under-resourced and marginalized populations at low or no cost, often through a community-based agency. A community-based perinatal doula is a community-based doula who provides doula services to individuals during the perinatal period, which we will also define. Director is the director of OPR, the Office of Professional Regulation. A doula is a non-clinical, non-medical individual who provides direct emotional and physical support and education and informational services to birthing individuals before, during, and after labor and childbirth. And perinatal means the period of time encompassing pregnancy, childbirth, and up to 1 year postpartum. So this chapter, often there's language in a licensure chapter or regulation chapter that says you can't use the title unless you are licensed or certified or registered under the chapter. This has that to some extent, but mostly what it's saying is nothing in this chapter should be construed to prohibit the provision of doula services by a non-certified individual. So non-certified doulas will still be allowed to continue providing doula services as they have been doing. You have to be certified in order to be a Medicaid participating provider once this gets up and running. So nothing in this chapter should be construed to prohibit the provision of doula services by a non-certified individual, provided that no one shall use in connection with their name any letters, words, or insignia indicating or implying that they are a state certified community-based perinatal doula unless they are in fact certified in this chapter. And there are penalties under the OPR statutes for violating that. Duties of the director of OPR, they must provide general information to applicants for certification, review applicants for certification, receive applicants for certification, grant and renew certification, and deny, revoke, suspend, reinstate, or condition certifications as directed by an administrative law officer, explain appeal procedures, explain complaint procedures to the public, prepare and maintain a registry of certified community-based perinatal doulas, administer fees that you'll see in the next coming up in the next sections, and refer all disciplinary matters to an administrative law officer, which is part of the OPR process. And allows the director, after consulting with their advisor appointees, to adopt rules as needed to perform their duties under this chapter. There are advisor appointees. Secretary of State will appoint 2 certified community-based perinatal doulas to serve as advisors. So this is one of the 2 ways that OPR regulates professions. This is one of in the advisor model. The advisors will be appointed as set forth in the existing law and serve at the pleasure of the secretary. It has some staggered appointments for the first term. Appointees shall have not less than 3 years experience providing community-based perinatal doula services immediately preceding appointment and must be actively engaged in delivering community-based perinatal doula services in Vermont during their incumbency. Requires the director to seek the advice of these advisors in carrying out the provisions of this chapter and entitles them to per diem compensation and reimbursement of expenses. To be eligible for certification as a certified community-based perinatal doula, the applicant must fill out an application as directed by the director by rule, send in the applicable fees, and provide evidence satisfactory to the director that the applicant is at least 18 years of age, has sufficient and appropriate competencies in community-based perinatal doula services, which can have been acquired through experience, mentorship, training, formal education, or a combination of these as determined by the director by rule, and have passed any criminal history background checks or registry checks required by the director by rule. The certification must be renewed every 2 years when the person applies for renewal and pays the renewal fee and provides proof of compliance with any continuing education or demonstrated competency requirements established by rule. Talked about unprofessional conduct, misusing a title in professional activity, and any of the conduct in the OPR unprofessional conduct statute, which we looked at a little bit in the context of S28, and allows OPR to discipline a certified community-based perinatal doula for unprofessional conduct. Section 2 just adds the community-based perinatal doulas as a profession under the Office of Professional Regulation. Section 3 adds community-based perinatal doulas to the list of list of professions for which OPR can inquire into criminal background histories. Section 4 creates the fees. So for initial licensure, it's a $75 fee, and for biennial renewal, it's $120. So $120 every 2 years thereafter. Section 5 adds Medicaid coverage for doula services, a requirement. It uses the definition from Title 26 that we looked at for certified community-based perinatal doula. It requires DIVA to provide reimbursement to a certified community-based perinatal doula for providing direct emotional and physical support and educational and informational services to birthing individuals covered by Medicaid during pregnancy, labor and delivery, and the postpartum period, regardless of the outcome of the pregnancy. And says that a certified community-based perinatal doula shall not receive reimbursement for travel time or mileage expenses. Section 6 provides legislative intent that the Department of Vermont Health Access reimburse qualified doulas in amounts that are reasonable and adequate for the services provided and are consistent with the rates set by other states' Medicaid programs. Doula services are covered by a number of states' Medicaid programs. Section 7 directs DIVA to seek a state plan amendment from CMS if needed, which I believe it is, to allow Medicaid to provide coverage for doula services. And Section 8 is the effective dates for sections 1 through 4, establishing that certification program will take effect on July 1st of 2026. But the director of OPR must begin the rulemaking process prior to that in order to ensure the rules will be in effect on that date. Section 5, Medicaid coverage will take effect on July 1st, 2026, or if a state plan amendment is necessary upon approval of the state plan amendment, whichever is later, and the remaining sections will take effect on passage.
I'm gonna go Maureen and then Topper.
Just a recommendation. I asked Kristen to upload the sunrise report. It's a really well-written
Yeah.
report and it's super helpful.
Thank you. Yes, that is
To
it is a
put
good
it
report.
on today's calendar.
I've very much informed this
Yes.
bill.
Topper.
In section 3, it says the office may inquire into the criminal background histories of applicants.
Yep.
Prior to that, on the initial one, says shall. So,
I'm sorry,
section 3,
section 3, this is
the office
existing language.
may inquire
Yep.
into the criminal background histories of applicants for initial licensure. Now, if you look in the beginning of it, well, I think it says eligibility.
They have to have passed any criminal history background or register checks required by the director by rule.
Yeah.
Is that what you're looking at? Bottom of page 4.
Have it. Let me just see if I can.
Very bottom of page 4. Very bottom, last 2 lines.
Oh, yeah, has passed any, and has passed any criminal history background or registry checks required by rule.
Right, so section 3 is just the authority for OPR to inquire, to make a criminal background, I can't say it, history check for applicants. So yes, it allows, so OPR by this existing law has the authority to inquire into criminal background histories of applicants for licensure. And as part of the eligibility, somebody must provide evidence satisfactory to the applicant that they have passed any criminal history background or registry checks required by the director by rule. So OPR may make that criminal history background check under section 3.
So here we're saying in rule that they have to pass a criminal background check. And then we're saying.
They're required, right,
Then we have to give OPR the actual,
right.
add that profession to the list of
So that's why you're saying-
professions.
Right, so this is, right, so this is authority for OPR, which is required by a number of, well, I think sometimes it's required by compacts as well, that our regulatory body have the authority to inquire into criminal background histories. So yes, adding community-based perinatal doulas to the list of professions for which OPR may inquire into criminal background histories, and saying as a condition of eligibility, you have, if so required by OPR, the applicant must have passed. OPR may check, applicant must have, if OPR checks, the applicant must have passed.
I'm still confused because it says the initial licensure and for license renewal. And the way I read the beginning, in the initial licensure, they have to.
They have to pass it if it's required. So if the rules enacted by OPR require someone who wants to be certified as a community-based perinatal doula to have passed a criminal background check, then they must have passed they must pass it before they can be certified. Separately, OPR needs the authority to inquire into people's criminal background histories.
So the mayor's given
So the May is giving OPR authority.
authority, okay. Good, thanks very much for that explanation. It's so precise that I understand it.
Excellent.
Any questions for Jen? Yeah, Alice,
Because I haven't had a lot of time reading this, but we just did a doula bill a year ago.
this is the result of it.
Yes, this is part 2.
Okay.
So you
That's
did
what's
it, yes.
confusing
So
me.
you did, this is great, and Senator Gillett can talk to you about it. So yes, you did a doula bill, and what ended up happening was there was interest in having OPR figure out the best way to regulate doulas so that they could be participating providers under Medicaid. So it was sort of a phased in steps in a process. So the report came back from OPR saying, we have looked and we believe certification is the most appropriate way to regulate. There are 3 levels: licensure, registration, certification. Certification is the middle. And OPR, I think, may be here tomorrow to talk to you about how they came to that conclusion. So now that OPR has recommended certification, this bill is setting up that certification program
So it's just an.
and requiring the Medicaid piece, right? So last year's ended up being hold on, let us do some investigation first. And then this is the next.
Thank
Yeah.
Okay. Thank you, Jen.
Yeah.
Oh, did you have your?
Okay.
Okay. I just wanted to, if I could, Nolan did a fiscal note and explains everything that you just. Nolan is next up. Great.
Although do you not pay, I don't know what Nolan's schedule is.
Are you okay? You're good. You don't have to be anywhere anytime soon. Okay. Yeah.
Thank you so much for having me. It is lovely to see all of you in this warm room today. I did. I did.
Yeah.
Okay.
Round two.
Is there air conditioning available? No? Okay. Thanks for having me and thank you so much for taking up this bill. I know time is short and I appreciate that you are prioritizing this at the end of the session. It's an incredibly important bill, as many of you know. It's been an ongoing bucket of work over time. It started last session and as Jen Carby just explained, it's sort of coming to fruition at this point. This bill is near and dear to my heart. I was someone who had 2 deliveries with accompanied with a doula. It was really important for me to have a doula at my births because I didn't have family local and I had a partner who traveled a lot. So I felt very alone in a lot of ways. And a doula was someone who was with me from, months before labor, during labor, all 30 plus hours of it. And then after labor during the postpartum period, which is critically important. I actually just read an article in, I believe it was the New York Times, about how maternal morbidity is so fragile for a whole year after birth. It's not necessarily, right around birth, but it goes on for a whole year. So having a doula in someone's life as a caregiver, as someone who understands, the importance of postpartum care is really, really critical. And we had some great testimony last year in our committee about, the critical nature of doulas when it comes to this time of life that is dangerous and scary, also very wonderful in many ways. So that is my personal pitch for doulas. There is obviously a really important financial component to this bill, which I think that a lot of you are aware of. Doulas don't cost a lot of money, although I was someone who was able to afford to pay for a doula. And one of the things that this bill is trying to do is to really make, especially community-based doulas, who really specialize in folks who need the care and who are typically from a vulnerable population. And that investment early on can just pay dividends over time. And I know it's hard to quantify that, but there is a lot of data out there. I recommend that you dig into it for sure. So yeah, as Jen Carby was saying earlier, we do have about 70 to 100 doulas statewide, and they practice all over the state. As I said before, they help pre-birth, during birth, and postpartum. When you're in the medical establishment, a lot of times your caregivers kind of come and go because they're on schedules. A doula stays with you for that whole period of time, which is huge. They also help with breastfeeding, which we know has huge impacts on health. And I wanted to say that this bill really codifies the work of that Sunrise Report. So what we're hoping to do is get that voluntary certification program going for those community-based doulas so that they can help the under-resourced, the marginalized, and the vulnerable populations at a very low cost. And the savings are enormous. As you will see, I believe, with Nolan's work. But a typical vaginal birth can range from $9,300 in Morrisville to close to $29,000 in Burlington, and a cesarean can cost $20,000 at Copley or $35,000 at UVM Medical Center. So a lot of financial savings are possible. A premature birth can be $61,000, and that just scratches the surface of the NICU costs. There is evidence in some of the studies that we've seen that women who received doula care had a 52.9% lower odds of a C-section delivery and a 57.5% lower odds of postpartum depression. So again, savings and downstream investment, very, very important. I am happy to answer any questions you might have.
Leslie.
I don't have a question, but I really appreciate this work, but I also really appreciate the comments about postpartum depression, which is totally under-recognized.
Yeah.
And having that kind of a year after support, I think is hugely important. So I really appreciate that a lot.
Thank you, Representative Goldman.
Right.
Hey, as the House, person on the House that has the sister, the companion bill, the same bill, I'm grateful to you for taking the lead and moving it forward. Did you have any testimony in opposition to all or any part of the bill?
We had no testimony in opposition. Our committee passed it out 5-0-0, and then I was also the presenter for finance. Finance also passed it out 7-0-0. And we had enthusiastic support from OPR. They are, you'll see when you have them in, but they are really enthusiastic about this bill and about doing the work.
How about Diva?
Diva, I'd like you to hear from them
Okay.
if you haven't already. I think that's a good idea. Yeah.
Ryan, did you have a,
Yeah,
or were you being sassy?
no, I was raising my hand.
Okay.
When we were looking at birthing centers, there was like some people who had issues with it. They don't have an issue with expanding access to care through doulas.
No,
Okay, good. It
no,
shouldn't be with birthing centers either, in my opinion, but I'm just curious.
no, like I said, there was no opposition. I do think you should talk to Diva because of course this does involve Medicaid. So I think that's a good idea, but yeah.
And if Medicaid collapses, like, we still would have a process to guarantee public safety through this bill. So it's not just about Medicaid, it's about creating like a, a way that people can know that their doula has gone through certain standards.
They have the money. They're gonna have to have the money.
Well, we're gonna be trading cows soon for healthcare, I think.
Thank you for bringing that up, Ryan. Appreciate that. Yeah.
But, you know, regardless of Medicaid coverage, just the consumer
Exactly, that's my
protection
point, is there's more
of
than one
having a
purpose.
certified profession.
And honoring a profession, you know, so.
Mhm.
Thank you, Senator.
Thank you very much for having me. I appreciate Chair.
We have
Black.
one left with an S number on it, so we won't see you again in this committee this year, so.
I'm
thank
sorry to
you.
hear that.
We would appreciate the reciprocation, you know, like.
Yeah.
Just need something there.
Yeah, we're working on it.
Feeling cold. Feel
I
free.
know, wow, okay, will do. Thank you very much. Thank you. Appreciate it.
Well, the hottie arises up here.
It does. I'm glad you have your windows open. Get some oxygen.
Wait, you're not gonna stay and watch me? I watched you. I'm
I'm
kidding. I'm kidding. I'm kidding.
She's had other important.
Yeah, true story. For the record, Nolan Langwell, the Joint Fiscal Office. Forgive me, it's been 6 weeks since I've actually talked about this. So I'm gonna be trying to remember what it is that I said and wrote. Okay. So there, so. So I'm going to try not to repeat too much of what Jen talked about, but I'm going to highlight 4 sections. One, section 1 talked about per diems. And I forget how, I don't remember what my estimate on it was, but essentially would require 2.2 certified community-based doulas to serve as advisors. They'd be entitled to the reimbursements. It was pretty nominal what we thought that would cost. It's just 2 people. We don't know how much they'll meet, but it's not a lot. It would be maybe like $1,000 or $2. It wouldn't be a lot of money, and it would easily, it's kind of money that's sort of easily absorbed within the budget of the department. So no appropriation required. I want to come out of the OPR special fund. Second is section 4, there's licensure fee. So this would have to go across the hall. No. They would establish a fee of $75 and a biennial renewal fee of $120 for the community-based doulas. It's estimated that there are approximately 70 to 100 practicing doulas in Vermont. So the estimated application revenue could range from $4,500 to $7,500 in fiscal year 2027 when the new licensure takes effect. So
You have on your fiscal note 45 to 7. Did you mean 75?
I wrote 75 in the note and I wrote 7 in the thing.
Oh.
So there's an inconsistency in my note. I'll just fix that. When you pass it out, I will update it. Third, is the Medicaid coverage reimbursements. This is sections 5 through 7. So again, mentioned it would require reimbursement to certified community-based perinatal. I can never say the word perinatal. I guess I just did. Doulas for providing direct emotional and physical support, educational and information services to birthing individuals covered by Medicaid during pregnancy, labor and delivery, and the postpartum period, regardless of the outcome of the delivery. And as Jen also mentioned, specifically excludes reimbursement for travel time or mileage. This would not take effect until fiscal year 2027. It also would require a state plan amendment from CMS to be able to do this, which can be a lengthy process. So maybe it would happen in 27. We don't know. But let's assume it does. And then the 27 impact will depend on the timing of the approval of the plan. So that's the first piece. So when do they actually approve it? Do they approve it in fiscal year 27? And the other piece will be utilization rates once it takes effect. Will people start using doulas? And when I looked at the various studies, they found that when this has been done in other states, in the early years, the spending is actually quite low because people don't know that it's an available service. And so it's one of those things, once the word starts getting out, it will start to pick up. But it's sort of like people don't know that it is eligible. So there was an education piece component to it. But once it's in effect, we expect that even if it were to go in effect in fiscal year 27, the utilization would be low, likely not to exceed a total gross of $426,930. And that's $176,000 in general fund. So that's the estimated potential Medicaid cost of 27. In the out years, the amount that was spent would, in theory, go up as the word comes out. I know where you're going.
Tell me.
Yeah.
Savings.
No.
Oh, okay. I thought I saw your thought bubble.
I'm hoping Leslie's going where my head's going.
Leslie.
What's your?
I'm
Okay,
just
sorry.
wondering how much doulas cost.
Oh, that's a great question. So there's also language in the bill. Where was it?
Priceless.
Yeah.
Priceless plus.
Yeah, that Eva has to go and investigate other states and.
Is that how it would happen?
I remember there was some intent language somewhere, right?
I mean, we know a general.
Oh, here it is. So section 6 provides intent language for DIVA to reimburse qualified doulas in amounts that are reasonable and adequate for services provided and that are consistent with reimbursement rates set by other state Medicaid programs.
Yeah, and I saw that.
Perhaps Maria can tell us when she
Yeah.
testifies.
Okay,
So
so that would be what.
it'll cost whatever they reimburse.
Yeah, yeah.
And
I was just
in
wondering.
in Diva's testimony they provided downstairs, and I'm sure they have sort of an estimate rate. And this is what the estimates of what they would pay for this service. So we do know what they will likely pay
Okay,
for the service, and that'll be in Diva's handout, assuming they bring it. And then, of course, times utilization.
My question, which Leslie didn't, we're clearly all on different pages. My question was around the utilization. What did you find in other states? Like the percentage of people who are on Medicaid who eventually or utilize the service of a doula? Because obviously not everybody's even gonna want to, even if they do know about it.
so it's my question times your question.
So if my last paragraph, under more information, I sort of touch upon this a little bit.
Okay.
And this was as of January 2024, because I did a little research on this. At least 13 states and the District of Columbia provided Medicaid coverage for doula services. However, utilization of doulas by Medicaid beneficiaries appeared to continue to be low despite demand. A 2023 case study of 5 states found that factors contributing to low utilization among Medicaid beneficiaries included lack of awareness of the benefit and workforce issues, low reimbursement rates, difficulty of enrolling as a Medicaid provider, billing codes that don't fully reflect the scope of work, and the administrative burdens of getting paid also may have affected doula participation. So there's a lot of things that pay into how that would all play out in the end. Does that answer your question? Ish?
I just didn't know. I mean, if you looked at one other state and, 20% of birthing people utilized a doula, or like if there were percentages of uptake.
So I think these studies looked at uptake by Medicaid beneficiaries and they found them to be low. So that's what those studies did. They tried looking at what was the uptake on it and they found them to be low. And again, for reasons of lack of knowledge and ease of being able to enroll in Medicaid, et cetera, et cetera.
Lack of doulas. I've got Daisy, and then I've got Mari, and then I've got Leslie.
I just want to point out that there's got to be a lot of variety in that data because Vermont not being a state that has freestanding birth centers and having lived in a lot of states that do have freestanding birth centers, doulas are very common in those states with freestanding birth centers because there's a space where doulas are normalized and employed so regularly. So I think us having passed that freestanding birth is going to take time, obviously, to implement. But I think maybe 10 years down the road, this will have much more of an impact on the ability for doulas to be accessible by folks who are Medicaid covered.
Mari?
Question about the appropriations. I know per diems aren't going to be an issue. And I'm guessing that we're not going to appropriate anything this year either because we don't have CMS approval and it doesn't take effect until July 2026. So are we avoiding the appropriations committee altogether?
No,
this year?
no, because the last piece that I haven't gotten to, there is an appropriation needed. It's not in this bill, it's in the budget. And that is for OPR. OPR would need. Thank you. November. So they would need an appropriation of 25,000. And this would be to basically get the profession up and running. It's a one-time.
Are they aware of it?
Yes.
Yeah, so it's the Senate captured it in part of their budget context. So it's part of the budget compensation downstairs.
Leslie?
So just looking back at the bill, I don't see anything addressing Nolan's last paragraph about lack of take-up. And wondering, and I know this, well, I'm just getting it on the table about asking or requiring AHS to be proactive in communicating with the birthing family about that benefit, to be very loud.
So I'm not sure how Medicaid gets the word out. Do they send flyers to all the pregnant women? I mean, I don't know.
I don't know either, clearly.
I think that's a great question for Diva when they come in.
Yeah, I'm just getting on the table.
Yep. All right. Any other questions for, yeah, go ahead, Woody.
Do we know whether CMS will approve this? I mean, it has for other states.
They have for other states. So it's just a matter of, how new administration in, do they have all the people in place? I don't know. I can't imagine. It doesn't seem that controversial. And there have been studies that show doulas actually help reduce costs. So yeah, we'll see. Good question, no answer.
I guess I wanted to let you finish because you were really on Medicaid reimbursements before we sidelined you. You just touched on it with Woody a little bit here. Did you find in your research anything about like future cost savings?
Yes. So I actually write in here that the out year could range between 500,000 to 1.3 million gross. depending on availability and awareness of certified community-based perinatal doulas and utilization by beneficiaries. And then I also talk about that while studies have shown that doula services during pregnancy, birth, and postpartum are an effective strategy in improving maternal health, we're unable to calculate the potential savings or offsets at this time. So I think it's safe to say, yes, there'll be an increase in what we reimburse for doulas. I don't know how we capture how much, if there's a way to capture those folks if they had gone to the hospital, how much more it would have cost, right? So I think that it's safe to say they're likely to be offsets, unless, of course, there's a few cases where someone has to, it becomes an emergency situation, they get rushed to the hospital, but those are not common. So it's one of those things where it will cost money and it will save money, and we don't know what either will be.
Great. Thank you, Nolan.
And we're doing this now, right?
No, we don't reimburse, but doulas exist.
They exist.
Yeah, they exist. We're just not, Medicaid isn't reimbursed for it.
They weren't
And the
certified. Yeah.
certification
and they-
is new.
And I also will point out, there is a doula in the room.
Yes, so we got.
Oh, beautiful. So we're safe if anyone needs services. All right.
If anyone knows how to survive after Medicaid, it would be doulas, since they've been around for thousands of years,
All right. So speaking of doulas. They have name tags.
Oh, I like to wear my name tag. People stop and talk to me and ask me doula questions. Thank you for having me today. I was here last year when this committee took up the bill, and it's nice to see some friendly, familiar faces. Thank you for your support in getting it here to where it is today. And for anyone I have not met yet, I'm excited to share the history with you and the bipartisan support that it's had. So my name is Maria Rossi. I've been a doula for almost 15 years. I'm also a social worker. I work for Washington County Mental Health Services, where I coordinate a doula program. Almost 14 years ago, with the help of Mary Moulton, who I know many of you know, who was our executive director at the time, I created the Doula Project at Washington County Mental Health. The Doula Project provides prenatal birth and postpartum community doula supports to those who receive Medicaid assistance and qualify for community mental health services. Our funding's a mix. We rely on grants, scholarships to pay for the birth support. We are community-based perinatal doulas. Before it was really an official name, that was us. Community-based doulas provide intensive, longer-range support with an emphasis on culturally congruent, community-based care to underserved individuals and families. With Sarah Teal, who's also here, I co-founded our statewide doula group, the Doula Association of Vermont. I'm here today as part of the Legislative and Advocacy Committee of DAV. I'm really grateful and excited to see the state of Vermont commit to maternal and infant health. The passage of S53 and the work of OPR and DIVA moves this legislation forward. It's especially important for our most vulnerable families and our communities who often experience the worst outcomes. Almost 40 years of data tell us clearly that doulas improve medical and mental health outcomes of birthing people, including reduced risks of premature birth, cesarean birth, higher rates of breastfeeding, and lower rates of perinatal mood and anxiety disorders, as we already touched upon. The leading cause of death in the United States, postpartum death, is suicide. So that should tell you something about the rates and risks of perinatal mood and anxiety disorders. Obviously, that has reverberating effects on a family and in a community. All of these health outcomes and mental health outcomes reduce healthcare costs, as you guys already talked about here, in addition to improving birth outcomes. Community-based doulas are also in a unique role to provide early intervention support to families when they're struggling. I've seen this time and time and time again, really more times actually than I can count. Doulas are a protective factor and have been underutilized for far too long. Dr. John Kendall, a pediatrician and researcher, once said, if a doula were a drug, it would be unethical not to use it. Since the last session, there has been incredible work building a thoughtful and thorough process for regulating community doulas through OPR and payment recommendations from DIVA as directed by Act 97. Both entities have collaborated with the Doula Association and other stakeholders to recommend a regulatory process and outline potential reimbursement model, which was strongly supported in the Senate. I'm happy to answer questions about reimbursement for doulas around Vermont outside of what's been proposed in this model as well. DAV, the Doula Association, wholeheartedly supports OPR's Sunrise Report on certifying community-based doulas in Vermont, and we ask for your support this year. Your support will enable us to move forward and spend this next year continuing to develop a just and in-depth regulation process, and that will take at least a year. 40 states are somewhere in the process of either actively covering doula support or somewhere in legislation. We have the advantage of learning from them, and I can speak a little bit about Medicaid in Vermont, pregnant people who receive Medicaid in Vermont, and a little bit about what's happened in other states too. I've heard some questions earlier. We know that a solid foundation is the key to successful utilization from the struggles that other states have had. On a personal note, I helped to write this first doula bill about 8 years ago, and I'm really grateful to be sitting here talking to all of you today. We've been working really hard to bring this work to fruition, and it means so much to so many people, and I really appreciate you listening. Thank you.
We took an enormous amount of testimony last year on just around in this committee on doulas, but we have 3 new members who were not in the 3 new members to the committee this year. I was just hoping you could kind of explain what's the day-to-day life of a doula? What are you doing?
Well, I would say that, my day-to-day life is a little bit different than a lot of other doulas because I do work in a community mental health center. And so we're doing much more expanded work. However, community doula, it's really all over the place. Most people, especially people who are doing this as their career, are serving people who are prenatal all the way to somewhere in the postpartum time. So a typical day may look like doing some birth planning, childbirth education. It might be accompanying people to appointments. We do a lot of that in our program, which is really, really probably one of the most helpful things that we do. And then of course, people are on call to attend to births, and that's all over the place. And a birth, can be anywhere between I just made it just in time to I've been here for 27 hours. So that is really an unknown that we're kind of always having to juggle. And then postpartum, there's a lot of home visiting support that happens postpartum. That can be sometimes, teaching infant soothing techniques. It might be brainstorming challenges around feeding a baby in whatever way that's happening. Sometimes doulas will do things like accompany people to maybe the first pediatrician appointment, following up with people, making sure that they get to their postpartum OB or midwife visit, which is a really big indicator of health, is people making those visits. And a lot of times it's a lot of talking and processing the experience, processing the transition to parenthood. As things come up, offering resources to people, be it community resources or therapeutic resources. Doulas are not clinical, and we generally know a lot about what's in the community and what's there for people. And so I would say that's sort of like a typical day, is any mix of those things. Many doulas work really sporadic hours because births can be really long and can be in the night and can be isolating in that way. So, yeah.
I want to be clear that it's not that you deliver or you're there as the support.
It's really emotional and physical support and informational support. There's a lot of in the moment education that happens, a lot of in the moment sort of emotional support that happens. There's a lot of, if there is a partner, there's a lot of sort of like support for the partner that happens, and sometimes even for the other children.
Mari.
Yeah, good to see you.
Nice to see you too.
Can you describe the nature of your relationship as a team member with midwives and?
Yeah.
other-
I actually really love talking about this because it's changed so much in the time that I have been a doula. When I was very first a doula, it was like there was a lot of trying to build relationships, and there was some, there was some apprehension of like, who are you? What are you doing? I'm not sure about this. And we've come so far that it's like, I feel very proud of it and also very excited by it and motivated by it. Most OBs and midwives that I know in Vermont would recommend doulas to their patients at this point, and that was very different than a decade ago. I think that most of the time we are seen as like a member of the team when we go into birth spaces, whether it's at the hospital or at homes or someday a birth center. And there are doulas who attend births at the birth center in New Hampshire, for example, for families who live like in that area on the border. So really, there is not the same sort of apprehension that I once saw. And some of our biggest advocates in Central Vermont have been OBs at CVMC.
Great.
Yeah.
Leslie, can you describe what's involved in the training and how that would lead to
Yeah.
certification?
So certification as it stands right now, separate from anything that OPR has recommended, is really, and this is why we needed a more streamlined regulatory process, is that there are over 100 certifying agencies in the United States or internationally. And some of them are very similar, some of them are very different. They're really all over the place. And most of them have some version of online learning or in-person stuff, but it's not the same. There's no like uniform way. There's no standards. And some of them are really great and some of them are less than great. And I've been through many of them, sometimes just out of like curiosity. And so once you finish that and some of whatever they set forth, that particular organization that you've paid for, they call you certified, like, but like I said, there's no uniform way, like what one person is certified and the next could be very different because they've gone through different agencies. So this would really streamline all of that and make it really clear what it meant. And community doulas are different. Community-based doulas are different than sort of, I don't like to use the word traditional because that's like dating way back, but I would say more like, common doulas that usually that entails less visits. Really, that's the big factor, is most doulas people who are not practicing in that community doula model are usually offering like a couple of postpartum visits, and that's it, and like maybe 1 or 2 prenatal visits. And that's perfectly fine for some families, that's all they need. And for other families, that's really not enough. Yeah.
Maureen.
I'll be reporting on the bill, so hopefully I have a prerogative to ask you more questions.
Out of the way.
I also appreciated, and I would like you to speak about this, the amount of support from doulas for this bill and for the process. And the
Yeah.
science report.
I think that by and large, there is a lot of support from doulas for this bill. In the beginning, I think there was some skepticism because other states had not played out so well in terms of reimbursement. I think, many years ago, the first reimbursement rate offered in Oregon was like $75. So people were like, well, I got to pay more than that to like have childcare and park my car. So that doesn't seem reasonable.
The entire pregnancy.
Yeah. And there was a little like apprehension, like, what does this mean exactly for us? But I think as the process with OPR unfolded, people really saw that this was not trying to overly regulate, but trying to sort of like streamline and ultimately, hopefully offer more support to doulas who want to practice as community doulas. We do have a shortage right now in Vermont. There is a workforce issue. We have built a training, and hopefully by spring of next year, we'll have trained 60. Right now, we have almost 30 people enrolled, and we'll do another one in the fall. So that'll be 60 folks added to the workforce.
I would say that there are in other parts of our healthcare system situations where a group of individuals, for example, I'm just going to use something from my own experience, IV nurses.
Yeah.
Asking to be certified, and there's no nationally accepted certification program. There may be accredited programs that you can get letters after your name.
Yeah.
But there's something about the process of creating a formal process where there are standards and ways to hold the providers of the service, in this case doulas, accountable in some way that I think helps. And I don't like this word. I wish there was another one that I could think of, but legitimize, like just to, in the public sphere, help people feel maybe a little bit more comfortable with the concept if they're not familiar with the amazing work that doulas do.
For sure. And we haven't really seen, if anybody has any pushback, any doulas have any pushback, they haven't been vocal about it because we haven't heard that from anybody.
Right.
Yeah.
Alan.
This is over my head.
It's okay.
Does the DAV, have you had data on what you've done up to this point with doula services?
Well, we're very, very new. So it's just in this past year that DAV has been born, so to speak.
Okay.
So we don't have a lot of data yet. Yeah.
Do you have either a projected or estimated numbers you might be involved in?
Well, I can't really say from a statewide perspective. I mean, I can say from Washington County, we get most of our referrals come from CVMC, from the center there, the Midwifery and Gynecological Center, or from other community services like WIC offices and Reach Up Economic Services. And I just did some looking at how many births in Washington County were from Medicaid and how many referrals that we got. So it's not really exact, but we get referred probably 40 to 50% of Medicaid births. We can't serve all of them, to be clear. We just don't have the staffing capacity to take that on. And we have to sort of cap it at sometimes periodically throughout the year. But and not everybody engages either. Some people, they just don't for whatever reason, for many reasons. But that is pretty high. But we've also been around for over a decade. That certainly wasn't the case for the first half of 7 years or something.
My last question is, it's going to be Medicaid services. Has there been any communication with insurance companies to?
Yeah, so from my understanding, I know that Rhode Island and one other state, I forgot which one, but Rhode Island and another state do require private insurance coverage of doulas. I know that Blue Cross locally has looked into it. They did an internal study. I don't know the results of that study. I don't know if it's done or not, but they were doing one at one point, and I know that they've looked into it. There are places in the country, California, where Blue Cross has covered doulas in as pilots at certain parts. What is the military? TRICARE does cover it, is my understanding. And I think there are other insurance, like Blue Cross, there are other private insurance companies that will reimburse. And then different, but in the same vein, there are a lot of larger companies like Google, Amazon, I don't know, there's a ton of them, Walmart, that will reimburse somebody for doula care. So it's not necessarily a covered service in their insurance, but it's covered as a benefit to their employees.
And I would just make mention that it's difficult for an insurance company to cover something when we haven't even created a system of certification for it.
I think that's why a lot of them have chosen to do reimbursement, because it's really tricky to do it otherwise. And that's my guess.
Woody?
Yes, just a quick question.
Yeah.
Not so much about what you do. I think I have an idea on that. But your association name, Doula Association,
Mhm.
in parentheses or in abbreviation is DAV.
Yep.
Is that a copyright?
I'm not sure if did we copyright it?
And the reason I'm asking is, DAV is also known as the Disabled American Veterans.
Oh, good to
And
know. Yeah.
I'm just curious whether there's ever been an issue with that. Obviously, that's.
Yeah, they're very different. There has not been an issue with that. It's good to know that though, so we can differentiate and make sure that we are clear. Yeah.
They're not gonna Chick-fil-A.
No, I don't know whether disabled American veterans would take issue. with
Yeah,
you
that's good to
using
know.
their-
Good to
their
know.
Abbreviation.
Yeah.
I don't know.
Okay, well, thank you. Thanks for coming in.
Sure. Thank you for having me.
So we're gonna take some testimony on this tomorrow from OPR and TIFA.